Well, welcome everyone to the BRS training on authorization updates. We'll be having several of these, so feel free to tell your friends. Um, uh, it's a small enough group, we can do introductions, which is exciting for me. So if you can just give your name, pronouns, the agency or organization you're with, your role in relation to BRS, and then anything specific you would like to hope to get out of the training, that would be excellent. I'll start. My name is Amy Gordine, pronouns she, her. I work with the Oregon Health Authority. I'm the policy analyst on the Medicaid team at OHA for BRS. And for me, I'm just excited to get any feedback or additional questions that will help all of you understand the process better. Monica, do you want to go?
Sure. Monica Moran, she, her, manager of OIA's Community Resource Unit. So I manage the team that oversees OIA's contracts with BRS programs. And my hope for today is to hear the questions from the members in the group and get answers so that after these trainings are done, our unit can be a resource for the folks who are having to navigate the process. Laura, do you want to go next?
Yes. Laura Ward, lead for Community Resource Unit, support for our field, and to stand in time of need if there are questions from our field staff. BRS is not my main frame of work, but it is a responsibility of mine to support and be informed and be present. So I'm more on the diversion side, individualized services side, but all the while still engaged. So, Chris.
Chris Ward, she, her pronouns. I work with OIA, community resources in an oversight role of BRS. And I just hope to get the updates so that I know how to answer questions if I have some from providers or the field. And I can't see who's next. Can someone choose?
Michelle.
Hi, I'm Michelle Allen, she, her, OYA Central Probation Parole. I'm the OS2 up there. And I am here because I want to learn everything about the process. I have a lot of people reach out to me all the time asking questions about it. And I just want to make sure we have everything accurate and make sure we're doing it correctly for our unit.
Thank you. And Kim.
Hey everybody, I'm Kim. I work, she, her pronouns. I work for Comagine Health. And so I oversee the BRS team that does the initial determinations. And I'm like Monica, I'm excited to hear the questions and get a good solid idea of how we can help make the process smoother.
Excellent. Well, the next item on our agenda is just to kind of go over the purpose of the training. So this process has been live for about 5 months now. We've definitely learned a lot. We've tried to obtain more resources to help with the process. And I imagine there will be more changes and adjustments to come as the program evolves and we continue to get feedback. So we're going to review process changes. We'll go over how to complete forms and also address some of those new resources. We'll go over some common issues that could help avoid delays or denials. And then we'll answer questions. It is a small group, and there's also a lot of content to cover today. Some of your questions might be answered as we go. So at least for now, if you could put your questions in the chat as you think of them, we'll address them at the end of the training. And that way, if the information's already been covered and you don't have that question anymore, we'll just move on to the next. I just want to make sure this is my first run of the training, so I want to make sure I can get all the content. And if for some reason we don't get to all the questions, we can follow up in a supplemental training specific FAQ. I it takes a long time to get just the general FAQ approved by all three agencies and our partners. So if needed, I'll do one specific for this training. So next up, I wanted to talk about the discontinuation of urgent requests. The BRS team at OHA, we had received several questions about the Medicaid-specific guidelines and criteria for what makes an urgent request. And upon further review, it was determined that per policy and processes, both federally and at a state level, that urgent requests are no longer available for BRS because from a Medicaid perspective, urgency refers to when a child is experiencing a physical or a psychological health emergency. And so urgency from a Medicaid definition would not be applied to BRS. And so they would be situations where the child would really need to be taken to the emergency room type of and receive emergency care. So instead, we have some other ways to get requests approved a little bit more quickly than the standard request. If necessary, there's a preliminary approval as part of the retroactive request, which we'll go over today. So I want to show you where to find information about that in case somebody asks you, well, why can't we do an urgent request anymore? So I'm going to share my screen, hopefully the right one. So OHA actually has a BRS website. And honestly, most of the time I just Google OHA BRS to find the website because it's easier than my long list of favorites. But you can do that and it will take you to our page. We're really hoping to start to build this page in a way that is more useful to our providers and our partners within the counties and child welfare and COMAGIN and OYA. So is that big enough or should I zoom in a bit? Make it a little, oh, there we go. That's a little nicer. So up top, we have where you links to our rules. This is the OHA overarching Medicaid rules, and we know other agencies have their own rules. And then we have some quick links that are specific to policy. So this would like take you to OHA's like really general rules and guidelines for OHA and our rule filings for overarching all of OHA. Over here we have our BRS forms. So we have currently the authorization form, the continued authorization or reauthorization form, and the code assistance request form. We have some quick links. This is an FAQ from a couple years ago when we went over with providers questions about admissions and reasons for denials, and that those can't be related to disability. We just uploaded, I will be sending an email to, the prior authorization FAQ. So that is there. We also have the provider enrollment process and the BRS Administrative Rules Guide. The program review is something from like 2015. Then we also have our rates and information about Medicaid match. There's recent rule filings. The last one was just about an update to our fee schedule. And then down here at the bottom, we have our BRS announcements. And so here we have the memo that talks about urgent BRS prior authorizations ended on the 11th. So you could click on this link and share the link with people, refer them to the website, whatever you need. But this does go over kind of more specifically what the definitions of emergency medical condition and emergency services are, where you can find those definitions and what to do and who you can contact if you have more questions. And again, it's definitely not saying that youth don't have urgent needs or that you all don't have an urgent need to, obtain services for the child. It just means from a Medicaid perspective, BRS is not an emergency service, and therefore urgent requests are not appropriate. So I'll go back here a little bit, back to our webpage. And then next, I just wanted to go over, we've received some questions and some confusion about the role that the licensed practitioner of healing arts, or LPHA, what their role is. And so I know since we have mostly OIA on the call, you have your own internal LPHA, and then Comagin, OHA contracts with them as the LPHA for the county contracts and for ODHS. But either way, the same is true. The LPHA's role per our Medicaid rule for BRS is to determine if BRS is medically necessary and medically appropriate for the child. They are not approving or denying the service. OHA is the agency that approves or denies the service. They are completing a review of the documentation you send in against our definitions of medical necessity and medical appropriateness. Those definitions can be found in rule, but also in the FAQ. And then it's just one component of what OHA has to use per rule to determine eligibility for BRS. And in the event that the LPHA, whether it be OIA or Comagin, has an adverse determination, meaning that per their review of the documentation, they don't think BRS is medically necessary or medically appropriate, or maybe there is insufficient documentation. Per our EPSDT guidelines, I forgot to spell out what EPSDT is. Early. Oh, I don't have it this morning.
I'll look at it. I'll write it in the chat.
Thank you.
You bet.
But those guidelines became effective the beginning of 2023. And for youth, any potential prior authorization or claim that's going to be denied has to be reviewed by OHA. So we have our Behavioral Health Management Committee, or the BHMC, which reviews any adverse determinations before making a final decision from OHA. Thank you, Kim. And then if the request is denied, the requester, the guardian, sometimes those are the same people, and the child, if the child is 18 or older, will receive a notice of action with additional information on how to appeal that decision if they want. So they would be appealing through OHA, not through Comagin or your LPHA. It would happen through OHA. And the prior authorization process is really to indicate that it's been approved for Medicaid to fund a BRS for that child that's eligible for OHP. So the next thing was to kind of go through the BRS website, and I kind of did that preemptively when I was showing everything else. In the event, when we were starting the rule writing process and we had community engagement, we provided links to register the community engagement right up top. As you can see, there are several different memos that we have listed here that you can reference. And yeah, that's where you find everything. That was an easy one. And then part of just going through the website, I wanted to talk about how to fill out the forms, since this is where you can find them. Although for OIA, they are embedded in JGIS. I don't know what that looks like because I don't have access to JGIS, but I know it does autofill a lot of the information for you. But if you ever needed to tell, maybe you're working closely with the county staff or something, they can find forms here. And they would just right click and open in a new tab, and it will open up the Word document. I already have some open and ready that I wanted to go through. So,
Amy, are the vast majority of counties using the JGIS form? Do you know?
I don't know.
Okay.
Laura, I think the JGIS form is primarily being used by OYA right now.
Got it. Got it. I will say the website is very easy to track and visualize. It's nice, and I really like the element of having the memos at the bottom. That's cool.
Yes, it's nice. I keep trying to get them to move it up above the rule stuff, but there's like a whole way things have to be organized. So I'm not cool enough to suggest that change. Oh, what? No, this is the wrong one. Here we go. Oh, it's open on the other screen. That's why I was like, why can't I see this? So I did two examples, one for just a standard request and one for a retroactive request. So we could go through both. So this is the form for when you're requesting that initial prior authorization. And the date of request should be the date that you anticipate you will be sending this request in. I understand that JGIS does fill it with the first day that you open it. So sometimes we see this date be a few days before it was submitted because requesters don't go back and change that. This is a new updated form, so you will see some differences. That is, we took a lot of the feedback and we had to remove urgent. So I believe that Heber, if he has not already, he is working on getting this up in JGIS. This is a requester's name, requester's phone number, requester's email. We get a lot of questions about why do I have to put my email here? I just literally emailed this to you. We receive a lot of emails. So when we make a decision for the prior authorization, we won't be replying to your initial email because that would mean going through several emails and trying to find it. So we rely on this document to pull the correct email from it. And also sometimes people go on vacation or people are working with other coworkers and want them to be included. And so for us to know that, it would either need to be captured here or in the notes section. I did this one as a county contractor, but OIA staff there's a drop down, and I think this autofills to OIA. And then county's only required if it is a county contractor, so those are only apply to OHA contractors. So only when is it a county contractor do you have to choose a county. This is a standard request. I'm requesting shelter care. My anticipated date of admission is the 27th. This is less than 10 days. 10 business days is the standard processing time for prior authorization requests. I've put this here just to make OHA aware of the anticipated admission date. OHA will do our best to acknowledge those dates and process accordingly. And this, you can see here, is this for standard requests. For retroactive requests, you would fill out information here. And we'll go over that later. I have the parent's name and address. I have the kid's name. I meant to update that to an actual kid's name. Anyways, and their mailing address, the kid's mailing address is important, especially it isn't in this case, the child isn't over 18, but in the event they are, we need to be able to mail notices to them. And we know some youth stay in care for, quite some time. So they could potentially turn 18 during the whole stay in BRS. It's important for us to have the Medicaid ID number. It's usually a couple letters, couple numbers, letter, number, letter. And then I pulled this from just how it seems like JGIS assigns numbers, which is usually 500, and then some more numbers. The diagnosis code is required. Sorry, I wanted to make sure I wasn't missing anything. Diagnosis code is required on all prior authorization requests for Medicaid. It supports the medical appropriateness for BRS and is required per rule, as mentioned right there. If you do not have that relevant diagnosis code, you can request for assistance. In that scenario, we have that request form, and we'll be going over those later today.
Amy,
So,
may I ask a quick question on that code? Isn't that also a code list that's on the website that you showed earlier? Is there a codes assistance form?
yes, we'll be going over that later. No,
okay.
You will not get a code from that list.
Okay.
There's no established list of a diagnosis code has to be provided by someone who is within the scope of their license or profession. So supporting documentation, I have attached agency county case notes and medical records from the parent and a risk needs assessment. And then in the notes section, I let them know that I will be out of the office during this time, and if they need me, they can contact this email. And then, so that would be the perfect place to say, you can contact my alternate, whatever the case may be. And here I just describe the situation a little bit more. So above I mentioned that I've attached some agency case notes, and the goal for this supporting documentation is to support the need for BRS, but sometimes it can include information that looks maybe in conflict with what is appropriate for BRS. And so this is a great place to fill in the notes and the gaps between those case notes. So I just indicate, and I don't work for a county or OYA, so this may not be like the terminology that people use, but I did my best at an example where I just described that the youth became physically aggressive with their mother, pushed them out of the way during a verbal argument so they could leave. And then I just clarified that since then, there has been no other instances of physical aggression and that the youth is responding well to strategies around impulse control. And then I just provide a little bit more information about why I think this youth could benefit from BRS services. And it's just, a few sentences that summarize what's probably already included in documentation. We get a lot of questions about like how old can things be. I think previously on the other form it said like mental health assessment and in parentheses within 1 year. And so there was some concern that people couldn't ever submit a mental health assessment if it was over a year. But we added instead a sentence up here that the documentation should be within the last year, but older documentation is acceptable if it supports that medical necessity and medical appropriateness. That could include if you have an assessment that's over a year old, that has a diagnosis on it, and that diagnosis is still relevant. Your documentation, especially if you have like notes in your agency case notes that indicate the youth is currently being seen by a mental health professional, documentation from that recent or current treatment providers is really essential to clearly understand the youth's behaviors and connect them to the need for BRS. So if you do have documentation that they are seeing a current primary care physician, a mental health provider, a substance abuse provider, or maybe they were recently discharged from an inpatient program like a substance abuse residential program or a psychiatric residential program, receiving those that documentation is really important because it will help further justify the need for BRS. And if we see that there's an established treatment provider, they should be engaged in this process of requesting BRS services and be aware that that's coming and can help support you all in that. We do acknowledge that there are some barriers sometimes to obtaining that information. Sometimes lawyers don't want that information released, and this is feedback I've heard. So we do acknowledge that that's happens, but we just want to indicate that it is really important to try and get those records if needed. So that is how you fill the form out. And when we go over the retroactive one, we'll go over then also how to submit it. Okay. So I'm going to shrink that one. And then, so this is the same form, but this is for when you have a retroactive request. So I'm going to take us back to the website just briefly. As mentioned, we have the FAQ here. You can right click on that and open it in a new tab. And it will bring up the FAQ. But you can also, we have a recent memo that went out on how to submit requests for retroactive BRS authorization. So you can right click on that and it will open up the memo that explains the process. And it has two steps to it. The first step, and this is how our rules are currently written. So definitely open to feedback as we, in the near future, get back to rule writing on the retroactive process. So first rule requires that you request preliminary approval. And this describes it step by step, but I will also show you. I have a little email here. So I'm not sure how to zoom on these. The first step is to email just OHA at the BHMC email because the OHA's team will review the preliminary approval first. You just let them, first of all, you have to send it securely. So for state staff, that means you can put this secure pound, and then you indicate it's a BRS preliminary approval request and you put the client's initials. You let them know that that's what you're requesting. You need to include the child's name, the child's date of birth, the Medicaid ID, the requester's name and contact information. So you don't have to submit the authorization form yet. In fact, we prefer you don't because there's additional information that we need before we can process the prior authorization. So it's just a quick paragraph about the reasons why this youth must leave detention on the 21st. We're looking at Boys and Girls Aid. This is the name of the provider accepting the child for admission. The planned date of admission is the 21st, and then a summary of why I think BRS is medically necessary and medically appropriate. And this is basically the same information that was copied and pasted from the other request. And then I let them know I've attached agency case notes, a risk needs assessment, and medical records from the parent, and that I've also requested current documentation from the youth mental health provider, but not yet received them. So you'll see I have attached, these aren't real documents, but I have the example risk needs assessment, and then I put the client initials. That's just what I prefer. The medical records. And then you send this off, and OHA, as long as we don't need to request additional information, will respond in 1 business day is our goal for that response. And push send, and that is this first piece of the requesting preliminary approval. You'll receive an email back, and basically for approved request, it means that you may proceed with the BRS admission, but understanding it's not a guarantee of Medicaid payment because it is not an official authorization yet. And then denied requests means that Medicaid will not pay for the BRS services retroactively. So if you do need to admit a child immediately, it will have to be covered by state funds. It doesn't mean that you can't still move forward and try and obtain additional information that justifies BRS and still submit a prior authorization request later. But it does mean at this point, we will not pay for them retroactively. And then the next step is to submit the BRS authorization form, and you're going to submit it to both OHA and then whichever LPHA your agency uses for, so for OIA, it'd be OIA BRS authorization email. And I have that form, oops, as well. So it's the same form we just looked at. The difference is we've checked retroactive. We're still looking at shelter care. We have, we don't fill out the standard request portion. We fill out the retroactive request, and you complete this after within 1 business day of the youth admitting. So if the youth admits on the 21st, you would want to have this submitted by end of day on the 22nd. And that is because rule requires us to, once preliminary approval is given and the youth has admitted, it requires us to process those requests quickly. We need to know also which day to retroactively approve back to. So the date of admission is important, so we know what date the child admitted, but then we also need confirmation that the services began that same day, because we can only approve back to the date that both these things are true, that the child admitted and services had begun. Same information around the parent or legal guardian, the child's information, the diagnosis code is required. And then you'll see on this one, I just also checked the mental health assessment, because in this pretend scenario, I was able to obtain that from the child's current provider. The note section looks very similar. I just let know I'll be out of the office, and also that I did receive preliminary approval. Now OHA knows that you received preliminary approval. We track that, but it can also be documented here if you wish. So then this is submitted. It just has a little bit different information, mostly in this area. And then this is submitted that a little bit differently than the preliminary request would be. It goes to both BHMC and then again, whichever LPHA you're using. So for OIA staff, that would just be the OIA BRS authorization email. again, send it securely, say what type of request it is, and that the client's initials. And then this is a much shorter email because you don't have to describe all those things again because they're on your authorization form. So just please see it. Attached retroactive PA requests and supporting documentation for John Doe. And we have the form as well as all of the documentation reattached because this time it is going to be HMC and OYA.
Amy, can I ask a question?
Do you mind putting it in the chat? And then I just want to make sure we get through everything. So that's how to go through that preliminary request form. There's also very similar information in the FAQ. So there's 2 different resources on the BRS website that go over that. And then the last authorization form I just wanted to go over quickly is the continuing authorization or the reauthorization form. We ask that this request is submitted to OHA at least 30 days prior to the end of the current authorization. That is because OHA is required to provide 10 business days notice in the event that services are changing in any way. So if for whatever reason the continuing authorization is not approved, we need to know ahead of time so we can do all of our internal review and send notice to the guardian and the child if they are over 18 to let them know that BRS has not been authorized. So that is why we ask them for 30 days prior so we can have enough time to follow those due process, which is client's rights. And then of course we'll request additional information if we need to. The request for continued authorization must include the client's most recent BRS service plan and 30 days of service notes from the current BRS provider. This is the area, the 30 days worth of service notes, that we are seeing the most confusion and the struggle. So I wanted to go over just quickly what we have in FAQ that talks about this more. So the service notes, are from the current BRS provider. They should be the most recent service notes. We understand sometimes it will take a while for the BRS provider to collect them and to submit them. So we understand if they're not exactly 30 days from the date you submitted the request, but once they start to get 6 weeks or more older, we may request additional information because we need to see the client's current status and how they're responding to BRS services. And it doesn't mean that the BRS provider can't submit additional information or that you can't gather additional information from the clients, any current treating providers they have. So if they're seeing outpatient substance abuse, outpatient mental health, if they're seeing a primary care physician, it doesn't mean that that's all the documentation you have to include. If you would like to include more can be included. We have a question about if you are a BRS provider, what is expected of you? And so this part indicates that the BRS provider is expected to provide the required information in a timely manner, and that they can also provide any additional information that they would like to. And then we've referenced this rule here. This is our Medicaid rule that requires BRS providers and their contractors to provide access promptly to any information or written documentation in its possession related to the client that we've requested. And by we, I mean any state agency. So I often recommend when you reach out to the provider to request information that you try and do so about 45 days before the end of the prior authorization. So then that way you can give them a deadline before that 30-day mark. And it is in rule that they need to be able to respond to those requests for information. So that's my biggest advice that I give people, is to set a due date. Say, I must have this documentation back to me, you know, by November 15th, so I can submit it on November 19th, you know, whatever the case may be. And then there's also some confusion about what service notes are. So it's my understanding that providers do not currently send service notes. They may send service plans to their staff, but not the service notes. Service notes are described in rule, and it describes each service they are providing to the client. And depending on what type of provider that is, that's 6 to 11 hours of service a week. So for a whole month, we should be seeing about 25 to 48 hours of services described in that 30 days worth of documentation. And it should include the name of the BRS client, the date of the service, the name and position of the staff member, the length of time that was spent providing the service, a description of the service, and a description of the BRS client's participation. What we are seeing is that individual counseling is considered one of the required hours, specifically from social service staff. So a lot of time that is the only documentation we're seeing. We're not seeing any of the other hours. So you may start to see requests for complete service notes if we're not seeing close. We're not doing compliance here. We're just, reviewing and seeing if it is close to this 25 to 48 hours. And if we get a request and we only see 10 hours, we know that that's not complete 30 days worth of service notes. So, and then it describes a little bit of what a service plan is. We have the initial service plan and the master service plan, and then the master service plan updates that happen. And the FAQ refers to all the OHA rules. So these are all active links that will take you to the rules. I know not everybody loves rules like I do, so I totally understand if we don't, if that's not useful, but it is there for you to reference, especially if you need to reference it to any providers. So that reauthorization form is submitted just like you submit your other PA requests. You would just, in the subject line, do your secure pound secure pound, and then BRS reauthorization. And then so this one I did from a DHS perspective. So I have child welfare here. This client was receiving, so one new change to the form is we have a drop-down list here. So you can choose which type of BRS the client is currently receiving rather than have to type it in. There's the admission date, and then the current authorization end date and anticipated discharge date. This doesn't have to be a specific date, but often in the master service plan, they have that listed, and you can pull it from there. Sometimes it just says spring of 2024. All of that is acceptable. The provider's legal name goes here, and their Oregon Medicaid provider ID goes here. The provider should be able to provide this to you. If you need to look it up, there is a way to do that. You can go to the provider enrollment page, and I'll put this in the chat. And they have a list here of active providers, and it pulls up this list here. And you can see I just did a Control F and search for Josephine County. They have a few different programs, but I finally found the Josephine County Juvenile Justice. This is their legal name. And then 06 provider type, that means they're a BRS provider. And this number that starts with 500 is their provider Medicaid ID. So this is how you can find those if you don't know what they are. I believe OYA also has a cheat sheet for y'all. So back to the form. And then again, same thing with the parent, legal guardian information. This is sometimes the same as the requester if they're in OYA or DHS custody. The child's name, date of birth, Medicaid, and their ID. Again, there's the diagnosis code. We talk about the minimum required documentations. I didn't realize till I was filling out this form that I accidentally uploaded a version that has comments, so please disregard that, and I'll be fixing that shortly. But we do have, you just check the boxes that you've obtained the BRS service notes, and we've provided a link there in case anybody has questions about what they are. And the current BRS service plan, there's an opportunity to check which additional information you have. And then the notes section. We may come back to this because I'm not sure if we have time. I had planned maybe a little exercise of discussing what kind of comments this team thought would be helpful to have here. So we may step back to that later. I want to make sure I get through your questions and all of the rest of everything. So again, once you have all that filled out and you've provided any information here, if there's anyone else you want the authorization sent to or communicated with, you'd want their contact information here. In your words, it's very helpful to understand why you think BRS is a good fit for the child from a medical point of view. So a child being court ordered into BRS is not sufficient from a Medicaid standpoint for the federal government and Medicaid to pay for the service. It has to be medically appropriate and medically necessary. So we're really looking at trying to transition from some people viewing BRS as a placement to a medical service. And that's really key about what we're doing here. And so if you were thinking about a child needing a medical service, why do you think they need BRS as a medical service? And that applies to all the forms, of course. So you want to go ahead and submit that. Am I still sharing my screen? Okay, good. I just wanted to double check. There's always that moment of panic. Okay, so we've gone through the preliminary approvals and retroactive process and both of the authorization forms. Next up, I wanted to talk about diagnosis documentation requirements. So if we go back to our OHA website, we have this memo here that talks about diagnostic assistance. And while we have this as an option, it is not, effort still needs to be made to obtain a diagnosis from any current or recent treating providers because they've been the ones that have actually seen the youth recently and treated them and met with them. The diagnosis is required for prior authorization and continued authorization requests. And specifically, we're talking about it being demonstrated as that ICD-10 code. So the letter with the numbers following it is what that looks like. A description is not sufficient. And so the memo talks about like what you should do. And again, you need to make the attempts to obtain those diagnosis code from following sources, which could include those current providers. So if you have agency service notes that you're submitting that says, Jane is receiving care from LifeWorks, you would need to reach out to LifeWorks and say, we are referring the child to BRS services. I'm requesting a prior authorization. Can you please provide any recent assessments or case notes that would support that need? And I didn't do the thing. So it's helpful to right click and open in a different tab, because otherwise, if you want to open something else, you have to push the back button. So apologies for that. Under the forms, the code assistance request form is where you can find the actual request form, but it also has additional information on it. So I'm going to open that up. So the form is pretty short. It may be changing a little bit based on just some things we've learned. Once you kick off that brand new process, there's things that you kind of learn right away. So it may be changing a little bit, and I'll go over what those changes might look like. But we didn't ask for like the date of birth or anything, because the purpose of this request form is to be submitted with the BRS authorization form. So if they're submitted separately, it's likely this will get sent back to you and ask you to submit it all together as a packet. So we know which youth, but we were trying very hard to avoid extra and duplicative information. So you have the client's name, and you're attesting that you have tried to find an ICD-10 diagnosis code from a medical professional and on the documentation you have, and that you've reviewed the attached documentation and not found an ICD-10 code, and then just your full name. So it then gives you some instructions on like how to review your documentation for an ICD-10 code. And oftentimes you'll find it similar to this, where it has a diagnosis description and then it has the ICD-10 code listed. Sometimes you will only find the description of the diagnosis, like over here in the terms, where it just says like other psychotic disorder not due to a substance or known psychological or physiological condition. That doesn't give you the code. So if you end up seeing this without the ICD-10 code, again, you can reach out to this provider and say, hi, we have your documentation here that lists the description, but does not have a code. Can you please provide us with the code? And if you do not hear from them, you can absolutely request assistance, and Comagin or your LPHA will be able to review this term and assign that code. If you don't find anything like this, but again, you see in the documentation that Jane is being seen by LifeWorks, you can reach out to LifeWorks, say, hi, we would like your current documentation, and can you please include any diagnosis codes that you've assigned to that youth? So, and then as mentioned, I'm trying to go through my notes. So those are the ways that you obtain it. And we do appreciate that you make those efforts. That is the expectation, because while our contracted and internal LPHAs can assist with identifying those codes, if the youth is currently being seen by or has really recently been seen by that PCP, a mental health professional or substance provider, and it's related to their behaviors associated for the need for BRS, the best practice is to request those assessments and clinical notes from that provider, including if they've had like a recent discharge from an inpatient like Madrona or the emergency department. but it is important to get that documentation from them to support the need for BRS. And then if the youth has not received any behavioral health services, that's when that description that you provide in the notes section of the request form is really key. And so describing any relevant life stressors that the youth or the family is experiencing could be gang involvement, drug and alcohol use, housing or food security, history of running away, all of those things that are contributing to the need for BRS. Having your narrative of that on the request form is really helpful. And then, like we mentioned, we understand that there's sometimes that information is difficult to obtain, or that you have timelines that you are contending with. So we may add to this document a date over here for the requester's name, but also some places where you can indicate any barriers that you had in obtaining information, because ultimately this is a Medicaid program, and attempts to coordinate care for a Medicaid member, there shouldn't be significant barriers to obtaining that. And so it could be some outreach that OHA needs to do with those external providers to let them know more about what BRS is. Again, I think there's some miscommunication in the community that BRS is a placement option, or that it's only accessible in certain ways, which is partially true, but it doesn't mean that it's not a Medicaid service. It is a Medicaid service, and that collaboration should be happening to get the OHP eligible youth the services that they need. So that's the form. Again, it has a second page that has a little bit more information that the memo has, and then that memo is also found down here. Where'd it go? There it is. Right click, open it in another tab, and that will keep your OHA BRS one open too. But the memo has additional information as well. So hopefully that would be helpful to your team. And if there are any updates to the form, another memo will come out explaining the changes, and the form will be updated. I think the last piece was just, I think I've done it as we've gone along, is to really talk about, oh, I wanted to grab the other one. That was a reauthorization. To talk about why this narrative section is most important. So really, as mentioned just a minute ago, if that youth has not received behavioral health services, or is being treated by their PCP for any of the behaviors related to their need for BRS, and this is a perfect place where you would describe the things that are going on in their life that justify the need for BRS services. And then it's also helpful if, like, the documentation that's described in any attachments that you have, if it at all seems to be contrary to what's medically appropriate for BRS, such as like recent suicide attempts, physical or sexual aggressive behaviors towards others, any psychiatric instability or psychosis, it's really helpful if you fill in the gaps there and describe whether or not these behaviors have been stabilized, what strategies are being successful in stabilizing the youth, and then why, despite that documentation, you think BRS is a good fit and an appropriate service for that child. And really any other information that you think is relevant. Sometimes these come in blank, and other times we see a lot of really helpful information, because your staff are the people that are working with these kiddos and know the kiddos. And I know sometimes they're new, so you might not have as much as a kiddo you've been working with for a while. But any information that seems relevant to why BRS is a good service for the youth is going to be helpful. And then again, if you're going to be out of the office, or if you're working with anyone you want included, this place is a good place to put that information. And the OHA staff record it on a tracker. So we make sure to send it out to all the people you've put there. So I think that is everything that I had on the agenda. So Michelle, I see your question. Is a JPPO supposed to go to the OHA site to get the forms? It's fine if they pull them from JGIS. Heber has the updated form, so he'll be getting those uploaded in JGIS. We're accepting both types of forms right now. We'll probably stop accepting forms probably around the beginning of the year, the older forms. Laura, did you have another question?
I did, but I don't think it's necessary. The only last thing I was thinking about as you were giving the example of information that's contrary to being eligible, I would think that might be a good bullet to add, because if that's what you're looking for and you're going to rule out, that might be information that would be beneficial to put as an example of what's necessary to include the first time around versus, getting it kicked back and then having to resubmit. So you were looking at the reauthorization form, but that little bit of information as a heads up, hey, don't forget this. If that's something that's going to be a rule out on an application or a reauthorization, that little bullet might be helpful, as you pointed out.
Do you mean define what
Yeah,
is
that last form
what's
that you gave.
eligible?
No, on the last form you gave examples of additional information that would be beneficial to include. When I looked through that list, I didn't see anything that spoke to that specific example of a rule out with conflicting information that I thought would be beneficial to put in there.
Yeah, so the second bullet point says clarifications on conflicting or missing information.
Okay, I just didn't read as quickly.
It's okay, I stopped sharing. So
Okay. I tried to read it. I was trying to be asking the right questions. There's just there's a ton of information.
Much information. And the FAQ is large. So I want to, well, are there any other questions so far?
One thing I didn't ask, and I will just go ahead and ask, and is the preliminary request form always required?
For any request?
Yep.
No, that only, the preliminary approval is only part of the retroactive request process. Yeah.
Okay.
If
Not
you
on that FAQ. I just can't go
Nope.
back to that FAQ and listen to you and follow along at the same time. And so I think that if there's anybody that's like me, holding off on questions and then having you go back is difficult because you're going through it really fast, Amy, and there's so much information that yeah. But I'm
No,
also not doing the work either. So don't let me misrepresent the vast majority of people out there doing the work that have been doing it since it started. So I'm just trying to get up to speed and understand the process.
well, I think that's valuable feedback because not all staff have received this training. We rolled out those first few trainings really fast. So I think that's really valuable feedback. And based on our time, I think I would have time to accept questions as we go. I just was a little nervous about today. So thank you for being the guinea pig. And moving forward, I will do my best to answer questions as they come up because that's a really good point and I appreciate that. So if you need me to go through anything, we can also always meet, separately, and that's available to anybody. I'm around.
You're good, Amy. I'm way behind. Like I should be not even asking questions.
That is not true. These are, I think the things you brought up were really important because not everyone has been in these trainings. Some people are relying on written instructions that were written before we tested this out and we found out so many things since then. So very valid points.
Those FAQs are going to be invaluable to follow a step-by-step process. It's like, I should have had them all up just so I didn't ask.
No, I think those memos will be helpful, and then we'll also try and get some updated step-by-step instructions. But we're hoping people will come to the trainings, which is why we're offering so many and recording them. I realized I forgot to go over how the FAQ is structured because it is 25 pages long, and but it has taken us that much time because every time we got close to wrapping it up, someone else would ask a really good question, or there'd be a new issue or a change. So it has taken us all 5 months to develop this FAQ. And that is why it's so long. But what we did is added a table of contents. So hopefully we have these kind of broad topics that if you want to read all these things, you can click on this broad topic. But if you have a really specific question, like about what is medical necessity and medical appropriateness, you can click here and it will take you to that. So you don't have to, you know, read through 25 pages of questions just to find what you're looking